Hello, everyone. Thank you so much for joining our webinar today on maternal, newborn, and child health and nutrition in the time of COVID-19. Today is both International Day of the Midwife and Global Hand Hygiene Day, and we're going to participate in a global campaign to clap for midwives and nurses around the world, delivering needed and clean care. Please share your audio now and your video if you're comfortable, and join us to clap for midwives and nurses for the next 1 minute.
Hello everyone.
I'm समझ रहा हूँ just thinking that because they were hopping on lessons learned, you know. Lesson learned rather than what we've been able to achieve. I wanted to say that just give example कटिहार किशनगंज में जहाँ हमने रखा कुछ भी नहीं हम लोग को अभी भी लगना पड़ रहा है. It's not that it's mostly what BMGF is thinking in बिहार का काम हो गया है ना. अब हम लोग को और जगह हम फोकस कर सकते हैं. लेकिन हमारा कहना था कि
में रख सकते हो क्या?
बहुत काम बाकी है.
Person is not.
That is the kind of message that I wanted to share in the first meeting.
Okay. Sylvia?
Hi, everyone. Thank you for bearing with us. We just ended clapping for about 1 minute to clap for International Day of the Midwife and Global Hand Hygiene Day. To participate further in that campaign on social media, you can use the hashtags hand hygiene and hashtag support nurses and midwives. Just going to share our presentation for today and we'll get started. Great. My name is Sylvia Levy, and I'm the Communications Officer for the ANH Academy. Today's webinar is organized by the Agriculture, Nutrition, and Health Academy, also known as the ANH Academy, in partnership with the Center for Maternal, Adolescent, Reproductive, and Child Health, otherwise known as MARCH, at the London School of Hygiene and Tropical Medicine. The ANH Academy, a work stream of the IMANA program, is a global network of researchers, practitioners, and policymakers from over 100 countries working at the intersection of agriculture, food systems, nutrition, and health. It aims to facilitate rapid learning and sharing in this fast-moving field. Through partnerships, we offer several activities, including webinars like this one. We recently hosted a webinar along with the Ag to Newt community to discuss COVID-19's food systems impacts, and you can find a recording of that conversation on our website. Today, I'd like to draw your attention to two specific points about the ANH Academy. First, we invite you to contribute to the ANH Academy's global community map, where we're collecting perspectives on COVID-19's nutrition and food system impacts around the world. Second, our annual conference, the ANH Academy Week, which usually rotates between Africa and Asia, is taking place at the end of June this year, and it will be held virtually. We hope to see all of you there. If you'd like to hear updates about the ANH Academy and more from us about the Academy Week upcoming, please sign up as a member on our website. The March Center, our co-sponsor for this webinar, brings together over 200 researchers from more than 50 different disciplines with the aim to improve the health of women, children, and adolescents worldwide. Here are a few announcements from March. First, March has an upcoming webinar series called Survive and Thrive, Transforming Care for Every Small and Sick Newborn, which will highlight the importance of inpatient care for the world's most vulnerable newborns and present the new WHO standards for small and sick newborn care. On the 20th of May, Professor Joy Lawn, one of the speakers in this webinar, will be presenting what the numbers say and reporting on experiences from Nepal. Second, the WHO has also put together a survey on health and safety of health workers in COVID-19 for health workers around the world to fill out. The link to that survey, as well as everything else mentioned today, could be found on the ANH Academy website. Today's conversation will be moderated by Sunitha Kadiala, Associate Professor of Nutrition Sensitive Development at the London School of Hygiene and Tropical Medicine. I'll hand it over to Sunitha shortly, but first we have a few technical announcements about Zoom. First, this webinar will be recorded and posted on our website later this week. Second, all participants have been muted, but please introduce yourselves using the chat function. Let us know your name, where you're joining us from, and the organization you work with. You can access the chat box by clicking the chat button at the bottom of your Zoom screen. This webinar will begin with remarks from our 4 key experts on global nutrition and maternal and child health. Following their presentations, we will open up the conversation with a Q&A session guided by you. If you have questions for the speakers or for the nutrition and health community, we invite you to share them in the chat box throughout the webinar, and we will do our best to raise them during the Q&A session. Last but not least, if at any point you experience technical issues, please check your audio settings and your internet connection. You can always try to reconnect to the webinar using the link we sent to you earlier. Thank you so much, everyone, and it's over to you, Sunitha.
Thanks, Sylvia, and welcome to everyone to this webinar on maternal, newborn, child health and nutrition in the time of COVID. We are so glad to have 4 experts with us today who have vast experience in maternal and child health and nutrition. We look forward to hearing from each of them and then the discussion after their talks, to which I hope you all will contribute. We are in the eye of COVID-19 storm, and the devastation it is generating is unprecedented. We are experiencing a multiple system breakdown, presenting us with cascading and compounding risks to maternal and child food, health, and nutrition security. Estimates project a 20% increase in poverty and a decline in real GDP of about 5% in South Asia and almost 9% in Africa. Without some significant interventions, this pandemic is likely to severely limit people's ability to afford nutritious diets and seek preventive or therapeutic health care for COVID or non-COVID conditions, such as institutional deliveries, routine immunizations, nutrition counseling, and treatment. Crucial health services and programs are in jeopardy as the health workforce is overburdened and working under hazardous conditions. Social distancing measures have decelerated, if not halted, service provisioning, not only in health, but in many other sectors, including food supply chains and agriculture, with ripple effects that are not even yet clear to us. While governments have boosted stimulus packages, the most vulnerable continue to face dramatic difficulties in accessing them at the time of need. This unprecedented simultaneous challenges to health, food, and social safety net systems threatens decades of progress on maternal, newborn, and child health and nutrition, particularly in countries and among populations where these gains have been so precarious. However, we can take lessons from past success stories in global health. In response to the HIV pandemic, for example, the past 25 years have seen tremendous investments to safeguard maternal, newborn, and child health. We have come together in the past to work towards a more equitable future, and we can do it again. We can sustain these gains through collaborations and system-level approaches to COVID and non-COVID-19 related agriculture, nutrition, and health programs. Global guidance, urgent investment, and international coordination is required to deliver the care, food, and other resources and services needed to maintain the health of women, children, and their communities through this crisis. To discuss such impacts and progress in response, we are delighted to have Joy Lon, Anuradha Narayan, Lawrence Grammer-Strong, and Sean Baker with us today, who together bring formidable country, regional, and global experiences and expertise. With us, they will explore COVID's impacts on health and nutrition for mothers, newborns, and children, offer ways of thinking about how we learn from each other to build a better future we all aspire towards, even in light of this terrible pandemic. Before I invite Joy Lon, may I ask you all to ask questions in the chat box and let us know who the questions are addressed to. There are several hundreds of people, happily for us, who are registered here today, and we might not be able to take all the questions, but we'll try our best to entertain as many as the time allows us. Our first speaker now is Joy Lon, Professor of Maternal, Reproductive and Child Health at the London School of Hygiene and Tropical Medicine and the Director of the March Center. Joy, please start whenever you're ready.
Thank you so much, Sunita, and greetings to everybody all over the world. Such an unprecedented time for us to be together. I hope that you can see my screen.
Yes.
If somebody, great, wonderful, thank you. So we're delighted to have this partnership between the March Center and Sunita and her group. We're particularly honoured to be doing this on the Day for International Midwives, and the topic that I have to start out this webinar is the direct and the indirect effects on maternal and newborn child health, including nutrition. So as Sunita has said, this is a 100-year event, the first global pandemic that we have had, and of the 250,000 deaths attributed so far to COVID-19, mostly these have been in China, Europe, and the Americas. But as well as this unprecedented change in global fear, as well as disease, we've had an unprecedented deluge of science, more than 30,000 publications so far in just 130 days. 100 vaccines already being evaluated, and rapid progress towards phase 2 trials, but still a long road ahead before we have a science solution. And so just in one slide to try and summarize, what are the direct effects of SARS-CoV-2 on maternal, stillbirths, newborn children and adolescents? And as UNICEF have said, children, and I would say also women, are not the face of the disease. In many ways, it's the older population and particularly men, but they're at huge risk of the indirect effect. So if we look at the direct effects, women are in a lower age group part of the epidemiology. Women are at lower risk than men. We know from the previous SARS epidemic that age-matched pregnant women are at higher risk than non-pregnant women with the same level of disease. So pregnant women are more vulnerable. We have very limited data yet on stillbirths. So despite now consistent registries in quite a lot of countries and a number of papers, there's very limited data on both stillbirths, the vertical transmission question, and newborns. We're confident that children are at lower risk, but although that risk is lower, we have, of course, millions and millions of children around the world. So with a pandemic, even with a low risk of death, we are going to have deaths in children and in adolescents. But if we think about the situation already for women's and children's health around the world, we still have a huge number of maternal deaths. There are already more maternal deaths per year than the total number we have seen from the COVID pandemic so far. For child deaths, we still have 2.8 million per year, and this is increasingly driven by stunting. We have 2.5 million newborn deaths in the first month of life, and we have an equal, if not higher, number of stillbirths each year, deaths in the last 3 months of life, taking the WHO definitions, and at the London School we work with WHO on those data. And then adolescence, while less an issue of death, is an important time of transition, both for nutrition and for long-term health. So in total, each year, we already have 10 million deaths of women, children, and stillbirths, and around 50% of those are at this vulnerable time around pregnancy and birth. And stillbirths remain still stillborn on that global agenda. And importantly, not only is the time closer to the time of birth, but the place is increasingly on Africa. So with current trajectories, by the end of the SDG era, unless we really change what we're doing, 75% of global maternal deaths and about 66% of newborn child and stillbirths will be happening in that one continent of Africa, which is about 14% of the global population. So if we look around the world for DALYs, for maternal conditions, newborns, children, and adolescents, and stillbirths, which don't count in DALYs as yet, we see really a map of where health systems are most vulnerable. So the continents of Africa and much of South Asia, and particularly in humanitarian settings. And these are the settings where already we have the worst outcomes for women and for children. And it's also the opposite to the map for the current COVID spread. So as COVID begins to move into community transmission across Africa and South Asia, this is going to highlight the struggles that our health systems already face. So one of the ways that we can look at how that could affect our health systems is to learn from history. So if we look at the Ebola epidemic in West Africa, this really picked out places where health systems were still in a post-crisis setting, so particularly Sierra Leone and Liberia. And if you look at the data on the left here, outpatient care in Sierra Leone particularly, but also in Liberia, dropped by about a quarter, and inpatient care dropped by about 44%. And you would think, well, maybe that's because there were already vulnerable health systems, but in fact in South Asia, and a lot of this data comes from Taiwan and places with extremely well-developed and robust health systems, there was also a major drop in outpatient care and inpatient care. And in Sierra Leone, we saw that cesarean sections half, maternal deaths and stillbirths increased. So if you look at this drop in coverage, what is that likely to mean for deaths in the places where we have had such hard won gains? We have 10 years towards the Sustainable Development Goals. So there's a paper published last week in Lancet Global Health from the group that work on LIST, the Lives Saved model from Johns Hopkins University, modeling based on lower coverage, what the impact could be on lives saved. So this is indirect effect of COVID with health system reductions in coverage. So if you had 6 months with about a 15% reduction in coverage of care, they estimate that around 12,000 excess maternal deaths and around 250,000 excess newborn and child deaths. With around a 45% reduction for 6 months, it would be more than 56,000 maternal deaths and more than 1.1 million child deaths. And the maternal deaths and also stillbirths and newborn deaths are particularly vulnerable to the loss of curative care in hospitals. So the biggest effects for death, the pathways where our health system has most need to be protected during these days are care at birth, inpatient care for sick newborns and for child infections such as pneumonia and also children with severe acute malnutrition. And a major driver for the child deaths is the increased prevalence of wasting. Immunization is critical, but because of the hard investments by Gavi and many around the world in our countries, what we know is that immunization is quite high at the moment. So we initially have a protection from herd immunity. Longer disruption to immunization services will result in a much bigger fall. And importantly, this links with the message of International Day of the Midwife. So one of the most vulnerable times in your life course is giving birth or your day of birth. And midwives are critical for this protection. So to come back to a summary slide of COVID through the life cycle, we looked at the direct effects, and in many ways, women and children are not the most vulnerable, but because of big numbers, there will be deaths. But the indirect effects are really important for us to consider. So as governments think about policies, as we in health systems think about what to do, protecting these essential services is critical, or we are going to see literally millions of excess deaths from indirect effect. And this is within the health system, but very importantly also intersectoral. So we know that gender-based violence has gone up. We know that support for pregnant women, new babies and mothers, breastfeeding and so on, are not just about the health system, but are about wider social norms and intersectoral support. Nutrition, food systems, disintegration, for example, of water and sanitation systems, loss of education particularly affects those who are already most vulnerable. And UNFPA have put out estimates for the effect on lack of family planning, but also reversals and some of the gains on female genital mutilation. So this is a devastating slide in many ways, but what I'm excited to hear from you on this webinar is, what are the solutions? What do we do to mitigate these effects? We have seen remarkable coming together of the global community to address the direct effects, and we need an equal, if not even greater, coming together to mitigate the indirect effects, especially on the most vulnerable. So collecting data, standardized data, we need to use those data to inform balanced policies. You know, yes, we need to do everything we can to reduce the spread of SARS-CoV-2, but we also need to make sure that we're not damaging the most vulnerable in the process of doing that. What are the innovations that work? And we're hearing stories every day in the media last week in Malawi, a local design group associated with the NEST consortium globally have developed local PPE and are printing that on 3D printers. Other incentives for workers, including transport, food supplies for workers. How do we realign staff so we protect the most essential services? How do we keep mothers and babies together after birth? How do we reach out on mobile platforms? How do we target those who are most at risk? And we need to be documenting these examples of resilience and innovation. A network like this that you have together enables sharing. How can we make sure that things that are learned in one country or one part of one country, in one clinic or one hospital, can be shared to keep things going? So thank you, and look forward to learning from you and thinking together how we can mitigate these effects. Women and babies and children may not be the face of the COVID epidemic, but they certainly have a major risk ahead that we need to do everything we can to mitigate. Thank you.
Thank you, Joy, for that. A very fascinating presentation of direct and potential indirect impacts, and your call for really not just, obviously we need to study the problem, but also seeking solutions to improve resilience of systems. That's really important, and we'd love to hear from the participants on what they are seeing as some of these responses, like the examples you have mentioned, and I'm sure many more. So now I would like to remember, I can see the chats coming and keep them coming. That'll be great, the questions. Our next speaker is Anuradha Narayan, Chief of Health, Nutrition and WASH at UNICEF China. Anuradha will be discussing China's experience of sustaining maternal, newborn and child health services during this epidemic. Anu, please start when you're ready.
Thank you, Sunita. I'm just going to share my screen here. Let me know if you can see it.
Yes, we can see it.
Okay, hang on. Excellent. So thank you for the invitation, Sunita, and to participate here. I want to start with sort of two caveats. One is obviously the government of China did enormous efforts to respond to the COVID-19 crisis. So what I am sort of talking about is just a sliver of the kinds of things that we as UNICEF were engaged with. So it's in no measure the entirety of the response of the government. And also just to remember for everybody that we were at the front end of this. So what we know now about the virus, we did not know in China. And we're literally learning on a day-to-day basis, many, many things that now we have started to understand about the epidemic itself. So just let me start by a very short slide that sort of gives you an overview of the situation. China's obviously at the other end. In Beijing, things are starting to come back to normal. We ended up with roughly about 82,000 cases and about 4,000 deaths. And that's sort of these numbers are, people are familiar with them now. Okay, there we go. Just wanted to go directly to the numbers that as they relate to pregnant women and children. And I think the larger point that I wanted to make was we still don't have a full head count of all the pregnant women who might have been affected, confirmed by COVID. But we do know that in Wuhan, there were about 118 women who have been reported, confirmed with COVID. And Wuhan really represents over 60% of the overall cases in China. So extrapolating from that, we don't expect there were too many other pregnant women outside of Hubei province or Wuhan. Similarly, roughly there were about 1,000 children within Hubei province. Hubei also represents, as I said, about 80% of all the cases. So outside of that, not that many other children are likely to have been confirmed with COVID. Great that Joy mentioned already that the impacts on women and children, the direct impacts seem to be limited, but the indirect impacts are huge. And that's the part that I want to make in the last point I want to make in the numbers is, you know, on annually, there are 14.6 million or so births in China, new children born in China. That means roughly about 1.2 million kids born every month, which means services for them because of the way the government had to establish their prevention and control measures were severely curtailed. So let me talk a little bit about the kinds of mitigation measures that the government had put in place in response to the outbreak. As many of you know already, the lockdown was pretty complete and intense, particularly for the Hubei province, starting in Jan 23rd, and then went on for about 10 weeks almost just for Hubei province. In other places, it was more, there was some differences and the let-up was a little bit sooner. Clearly, the Chinese New Year holidays were extended and then everybody was sort of either shelter at home or teleworking modality. Schools were closed, all public services, all parks, everything was closed. And very highly restricted access for communities, no matter where you were. So across all provinces, we saw the same kind of approach. But at the same time, the government also did very much about sort of high levels of non-pharmaceutical interventions of social distancing, wearing masks, hand washing, all of that. They continuously revised their prevention control measures. There were 7 different revisions that were put out. And obviously we've all heard already about how they built hospitals. Wuhan built a 10,000 bed hospital within a 2-week period, or actually less than a 2-week period. But some of the actions specific to pregnant women and children that, again, early days, because we didn't know enough at that point, was to prevent infection, complete suspension of breastfeeding for all newborns, for mothers who were confirmed with COVID, very limited visits for anyone, for mothers who are pregnant or for children asked to stay away from hospitals, which did result in what Joy also just mentioned, significant reductions in antenatal care service, suspension of all vaccination services for about 8 weeks, except for some essential ones. We actually ended up calling some of the facilities and communities that UNICEF directly works with. We did a sort of telephonic survey, and these are the kinds of issues that we ended up finding in discussing both with mothers but also with healthcare workers. Significant amount of caregiver anxiety because there was so much information coming in on a day-to-day basis and not knowing what are the right things for them to do, including taking children for illnesses that they typically would have sought care for. So, China has a very highly well-developed healthcare system, high levels of immunization, and very much use of health services is extremely high. But this we found out that actually there was significant plummeting in the use of services. The flow of services changed, so women were unsure about if they were pregnant. They had a plan about where they were going to deliver babies, but with COVID and non-COVID designated facilities, a lot of the services had to be changed. We actually saw an increase in C-sections, and then of course, as I said, breastfeeding rates, which are already low in China, really plummeted significantly as it was suspended. And then we obviously also saw significant donations in breast milk substitutes and infant formula. And with my long history of working in nutrition, I would be remiss if I didn't make this point about how a situation was actually worsened because China doesn't have a code against the marketing of breast milk substitutes. It expired a couple of years ago, 2 years ago now, but the government hasn't reinstated it. So it provided an ample opportunity for both promotion, brand promotion, as well as significant levels of donation that happened through the period of COVID. And because there is no mechanism to actually document these violations, I think these are impacts that we are going to have to deal with many months and many years down the road, actually. So despite all these sort of, actions that we saw that might have a negative longer term impact on mothers and children, I do want to point to 3 specific actions that we think the government actually did do to safeguard services in particular. And the one thing that they did do that we must credit, and I think many countries might want to learn from or think about, is a very, very strong risk communication engagement. So constant updating of information, using all different media channels, making sure that there was some opportunity to actually listen to the kinds of issues that people were concerned about and responding to that. I think just on maternal and child health, over 33 products were sort of put together over an 8-week period. And here UNICEF was very engaged with the government of China on this particular aspect. We helped them craft an initial round of question and answers, like FAQs, that were the ones that we identified were of most importance to mothers. And that helped create a range of products that could be put out, including how do you protect yourself? Where do you seek maternal child? Where do you seek services? How do you know where, what are the kinds of issues to sort of monitor your health? And we found that these kinds of videos, small posters, social media posts, were huge levels of uptake. I think our own activities reached over like 70, 80 million people. And this is not counting the government channels or government products, which reached, of course, many, many millions of more people. The other thing I think also interesting and useful for others to consider is really about online training. What we quickly found was much of the training that was provided and did go online almost immediately was almost entirely focused on the clinical side of things, how to treat and manage people who do have COVID. So for the vast majority of others, where there might be fevers who might be coming to non-COVID designated facilities, or pregnant women who may not understand their symptoms. So maternal child health workers across the board who may not be in the front line, but still very much part of the health system, certainly needed also training on some key areas. And so we helped develop with the China CDC modules that were focused primarily on retaining and maintaining services for that could include some amount of online services that could be pulled together. And now all these materials are actually available through the National Health Commission's website, and I have provided where people can go. They've also been translated in English so they can be made available to the audience. And the final point I want to make, and this is really my final slide here, is the fact that we need to continue to sort of use data effectively and advocate. Finding and getting data in early days was difficult in China, and we still have many unanswered questions, as you know, even across the board. So opportunities like this to share is very important, but also using the information that you do have to advocate for things that you can right away was important. So one of the first things that we did with WHO colleagues, both from the region but also in country, was actually crafting information that we had at the moment, asking that the government revisit its policies about isolating newborns immediately after birth, not supporting breastfeeding, because we felt over the long term that was detrimental. Now, we didn't get much progress on that yet, but I think these are opportunities that we cannot give up, because we must continue to use our voice and sort of find ways in which we are not forgetting longer term impacts that are likely to happen in women and children, while we also deal with the direct and immediate impacts of COVID. So I'll stop there, and I'll be happy to answer any questions that you might have. Over to you, Sunita.
Sorry, just unmuting. That's fascinating. And I especially like your last slide about social listening. There's so much of data and non-data that poses as data, and all kinds of things happen. And there are so many questions actually regarding breast milk substitutes and breastfeeding guidelines and so on and so forth. So we'll get into it. But I think, how do we use data, and what kind of data is considered credible? How do we help people in general understand the difference between rumors versus data science, basically, is super important. And a lot of lessons from China and all the guidelines. I'm glad to hear that they're all available in English for various countries to take up and adapt to their conditions and needs. Thank you so much for that. Lots of questions in the chat if you want to monitor and pick and collate yourself, but we will call out some of these themes as well. And now we are on to our next speaker from WHO, Lawrence Grummer-Strong, Coordinator of Food and Nutrition and from the Department of Nutrition and Food Safety. Sorry, the screen went full blown and I forgot the exact title. I'm not terribly good with titles. I apologize. And he's going to talk about breastfeeding and in the context of COVID. So some of these questions we are seeing coming through the chat box about breastfeeding will be further clarified during Larry's presentation on definitely what to do and definitely what not to do, I suppose. Thank you, Larry. On to you.
Good afternoon, everyone. Good morning and good evening, depending on where you're listening from. So happy to share with you information about the WHO guidelines on breastfeeding in the context of COVID-19. Our main guidance on this was released on March 14th, just as much of the Western world was moving into its lockdown mode. And these came out in clinical management guidelines that were published as interim guidance They were published in the context of all of the clinical management issues around the management of COVID-19. And the recommendations are fairly simple. They recommend that despite whether a mother is COVID positive or COVID negative, she should be recommended to feed according to standard infant feeding recommendations. So nothing has changed. They should initiate within the first hour. If she was a pregnant woman that comes in to deliver, if she's found to be positive while she's already breastfeeding, she should continue exclusive breastfeeding for the first 6 months, continued breastfeeding with the introduction of complementary foods starting at 6 months out for 2 years or beyond. So really no change in our recommendations there, regardless of COVID-19. However, we do recommend that in that context, she should be using the infection prevention control measures, including the use of a medical mask, washing her hands before and after caring for her child, disinfecting any surfaces that the child would be coming in contact with. So just be adding the IPC measures onto the normal breastfeeding. In contexts in which she might be too ill, that she's not able to continue breastfeeding directly at the breast, we continue to recommend the expression of her milk so that she can maintain a milk supply, as well as provide that milk to her baby, and recommend that someone else feed the baby that milk because she's not able to provide that care. And we're very clear that we are not recommending that there be a separation, that we need to have the mother and baby continue together. If this is in the context of a newborn, that we should have skin-to-skin contact or kangaroo mother care. So the standard recommendations continue to be applicable there. We actually developed this decision tree or flow chart to document that feeding. And what you see is, regardless of whether or not the mother is positive or negative, we still end in a box that we need to support that mother to breastfeed. And the only difference is that for that mother who is COVID positive, we add in this use of masks and potentially cleaning her chest if she's been coughing onto her chest. But then we also have to look at, well, then what if she's not able to breastfeed and is not able to express her milk? And we look at other options that there are for the feeding. The guidelines go into the option of using donor human milk, if that's available in the community. If it's not available, then to look at options for wet nursing, if that's acceptable in the context that they're living in and is socially acceptable, and the safe wet nurses can be identified. And only after all of those options have been ruled out would we turn to breast milk substitutes as an alternative. And in each of those contexts, if the mother wants to come back to breastfeeding, then we would put in place relactation support services so that she actually can return to breastfeeding. This does not become the end of her breastfeeding experience. Why does WHO recommend this? And the primary issue here is that we have to consider not just the potential of transmission of COVID-19, which seems to be the focus of many new public health policies, but we have to balance this against the proven health effects of breastfeeding. And so, as Joy was pointing out in the earlier slides, we have continued concerns about the mortality and morbidity that could be there if we actually stop the routine services and the routine feeding of children. To date, we have not seen the virus in any testing in breast milk, and we don't have any documented cases of vertical transmission of the virus through breastfeeding. That doesn't mean that we may not find these in the future, but we expect that the risk must be quite low given what we've seen so far. We also know from previous experience with breastfeeding, and particularly in the context of other coronaviruses, that antibodies and bioactive factors that are in breast milk may actually be providing a protection against COVID infection. We expect that the baby is likely going to be exposed due to household exposures, other nosocomial infections, et cetera, are potential risks that the baby could get COVID-19 regardless of whether there was separation. And so we actually need that breast milk as a protection. We also know that there's been very few cases of infants actually catching COVID-19. And in those few children who have been infected, typically their illnesses have been very mild. And so while we wouldn't want to expose a child intentionally to COVID-19, the protection against the transmission seems to be a minor factor when we balance it against all of the health benefits of breastfeeding. So to help communicate this, in addition to putting the guidelines out in March, we have published some FAQs where we go through 20 questions that people have asked about these guidelines. How do they actually get applied? Some of the science behind them. So to provide much more background for people, as well as include that decision tree so that it's easily accessible for people. We've put out tiles on social media to try and get these messages out to people and easy communications. We know that many people are not going to read through complicated guidelines, and so we want to make sure that that message is getting out very widely, that we continue to support breastfeeding. We haven't stopped working on this. We are in the process of revising the guidelines now. We'll be moving to version 3 of the guidelines within the next couple of weeks, trying to address some of the questions that have come up. We're not going to back away from the guidelines that are there, at least it doesn't look like we are. But there are questions such as, what if a medical mask is not available? Should the mother continue to breastfeed, or is that, if we're not able to have the infection and prevention controls there, is that a reason that maybe there should be some separation? At this point, we don't believe that that is necessary. We have to clarify that with guidelines. Should the chest be washed, as I mentioned earlier? What about non-breastfeeding mothers? Should there be separation? Are we only doing separation or doing non-separation in order to preserve breastfeeding? And so we have to address, what about those other babies who are not breastfed? We're developing a clinical modules app that would be on your phone app accessible for clinicians to apply these. We're developing a video about breastfeeding and COVID-19 in conjunction with UNICEF. We've published counseling cards and messaging documents about this to try to get the word out. But I just want to finalize with a comment on that we really are not only concerned about the case of the COVID positive mothers. There are a number of spillover effects that might impact breastfeeding more generally in the community. As was shown earlier by Anu, we're seeing increased promotion of breast milk substitutes using the pandemic, using the current situation of social distancing as a premise for increasing the marketing of infant formula. And so this may have a downward pressure on breastfeeding. We're very concerned there. Secondly, we're very concerned about the continuity of programs, as was mentioned earlier. Many of the support programs for mothers happen in communities, and so as we have social distancing and people are not allowed to circulate about in their communities, the ability to have mother support groups that we know are highly effective, outreach by community health workers, other ways to help mothers with their continued issues with breastfeeding, to support them, are under significant strain. And in addition to healthcare systems themselves, people are often not coming into the healthcare systems, sometimes because the healthcare staff are not available. They've been redirected to be supporting the testing procedures or the care for COVID-19, and so they're not available. Or sometimes people just don't want to go to the health facilities because they are afraid of catching COVID. They don't want to move out there, or the social distancing rules have made it harder for them to transport to them. And so it's very difficult to maintain these health services, particularly when it comes to a kind of routine care of non-critical issues, but that supportive breastfeeding that we would normally see in those environments. We've also seen a number of environments where people are not following the guidelines to not separate, and as we heard earlier, are not supporting breastfeeding, but they're extending it even beyond the COVID positive patients, and they're actually just putting in a routine separation of healthy mothers and healthy babies, because they're saying, well, just as we want to have distancing between people in the usual environment, we wouldn't want to expose a newborn to potential risks of an asymptomatic mother. And so we're seeing that kind of separation happening. So many threats to breastfeeding that we really need to address. So I want to thank you for your attention today, and happy to be part of the discussion later on. Thank you for your attention.
Thank you, Larry. In a way, that's a bit soothing, but a bit fearful, but also a bit soothing, in the sense to know that we haven't seen transmission virus in the breast milk. That itself is a huge, I think, silver lining, if you can call it that, in this, what has been a very tough pandemic. So that's great. We have a great foundation to build on, and hopefully it'll stay that way. And the challenges, of course, resonate with what Anu also said. But Glad to see that these guidelines are being developed, and clearly there is a huge and eager interest and need for this. Thank you for taking the time, and million questions there in terms of, you know, what and what not, and what if masks are not available, or, you know, all the different varied realities of how people live and how to cope with that. I'm sure you're thinking of all that, and there will be questions. So thank you so much for that. And love the baby on your last slide, as always. Thank you. And now to our last speaker, Sean Baker, who is started his job, recent job as a chief nutritionist at USAID. Apparently he's 3 months old in that job. And apparently this position is the first ever chief nutritionist at USAID. Congratulations, Sean. He'll be discussing about multi-sectoral programs and multiple ways of dealing concerns of various systems in response to COVID. Sean, on to you now.
Thank you, Sunita, and I'd like to also thank everyone. I see there are upwards of 500 people on this webinar, and the way that this pandemic is affecting every part of our lives, I'm greatly appreciative that people have taken the time to focus on these issues of nutrition and the devastating consequences of this pandemic on nutrition. Ingrid is presenting the slides for me, so I'm going to ask her to go to the next one. I think, Sunita, in your opening remarks, and others have referred to this, I think probably all of us around this virtual table have in our minds some sort of a conceptual framework of nutrition. We usually think of the sectors and the systems that need to deliver on good nutrition: livelihoods, food systems, health systems, social protection programs, humanitarian response, because there's a large burden of undernutrition in situations with complex emergencies, and we need to generate political momentum for nutrition. We are really in this situation of a perfect storm where every system we rely on to deliver good nutrition is being disrupted, not so much by the disease itself, as people have pointed out, but by the measures put into place to control the disease. I also, and I will unpack a couple, so I'm not going to go into each of these because many people have covered them. The points that perhaps I would add on, I think there's not been a specific discussion yet around social protection programs, and I won't go into that in detail. I will focus much more on the food systems. But in normal crises, social protection programs are one of these fundamental buffers. But we're also in a situation where some social protection programs have just had to be halted, some are disrupted, and there's seldom any case where the incredibly increased demand for social protection can be met by flexing these programs to expand it. The other one, and I think it's been alluded to also, is what I call the misinformation pathway. I was struck in a call with one of our partners 10 days ago. Their organization works with smallholder farmers and producers and food processors, and they had surveyed through telephone surveys a number of smallholder farmers across Africa and various countries. And there was this paradoxical finding that the more connected the farmer was, the less quality health information that farmer had. Because I think we see that misinformation in this connected age takes on a life of its own, and there can be all this misinformation flooding the social media, et cetera. And so making sure that we're very clear about our messaging around the issues is so critical. The other that I think we need to be very careful of, and it's also part of our messaging. We within USAID are using the terminology of secondary impacts. Here we use indirect impacts. That's not very compelling to a decision maker. But we're seeing that the devastation that this pandemic could have on nutrition, we need to elevate that message so the decision makers are taking those impacts as seriously as they are taking the disease itself. And in nutrition, I think we've made headway, particularly since 2008, of better political positioning of nutrition, and we cannot afford to let that political momentum wane. I think I appreciated very much the presentation where she started out with just how much rapid learning we're doing here. I think we all need to go in this understanding we're learning by doing. But one thing, and there are many things we don't know about this pandemic and how it will unfold. However, I think that what we can see is in any shock, and this pandemic specifically, it's only going to exacerbate those pre-existing vulnerabilities. So we know those populations who have historically been the most vulnerable, be they geographic excluded populations or moms and kids in that 1,000-day window, they're going to bear a disproportionate amount of the burden of the shock. And so we need to make sure that we are focusing our efforts on the most vulnerable, whom we've all worked to serve. Ingrid, if I could go to the next slide, please. And so as we go forward, what can we do? I come back to the top line. I think we need, as a nutrition community, to have a strong rallying call that we cannot let the legacy of this pandemic be a generation of children who've lost their lives and their potential to malnutrition. Because as we know, if we do damage in that 1,000-day window, we really can't recover that damage in terms of the excess mortality that creates and the loss of potential for those children not actually growing up to achieve their full potential. We need to have better evidence, both through projections of the likely impacts of this pandemic on nutrition, and monitor to understand what are the changes that we're seeing and how do we adapt our programming to meet the needs of the people the most at risk. And I think, if anything, we need to, again, engage in the policy dialogues to make it clear why nutrition should not be an afterthought or a secondary impact or an indirect impact of the COVID crisis, but is really a development imperative through this crisis, the response phase and the recovery phase. I wanted to move now to some of the things specifically the US government is focused on at USAID. If I go to the next slide, Ingrid. Our top two priorities are saving the lives and making sure we're protecting development gains. I think, and it's very much centered on those two top priorities that our responses are framed, and positioning nutrition as an essential life-saving sets of interventions we need to safeguard during this crisis, and that we have made progress in nutrition and we cannot allow us to backslide on those gains. As I said, within the US government, we're referring to secondary impacts, but rest assured, we're seeing these secondary impacts of absolute primary concern. The other point I want to underscore is the need to generate better evidence. I think there's a lot of conjecture about what the impacts of the crisis might be on nutrition and food security. But we need to have a better all-up understanding of the situation, what the likely situation, and then how do we prioritize. Nutrition, because of its very complexity, of course, when you see analyses, it will be, okay, will be this much economic damage, and then we know if GDP decreases, what will be increases in stunting? Or, for example, the Hopkins article that was referred to earlier, if we see reduced coverage from the health system, what might be the likely impacts, et cetera. So the analyses to date are still fragmented, and we don't have an all-up number of what's the totality of the potential impact. And I think that's going to be very essential, both to position nutrition as a priority during this crisis, as well as to help us sort out when we have to prioritize, where are we taking the biggest hits, and then how do we prioritize the pieces that we need to protect going forward. We are working on what we've done internally, we're really scrambling to work with our implementing partners, our partner governments, to how do we adapt first existing program to continue to implement during this crisis. Within USAID, and Sunita, coming back to your introductions of this role, which is now 3 months old as of today, of chief nutritionist, as within many large organizations, parts of nutrition sit in different parts of USAID. Principally, there's the Bureau of Humanitarian Affairs, which combines Food for Peace and the Office of Foreign Disaster Assistance. There's the Bureau of Global Health, and there's the Bureau of Resilience and Food Security. And what we've done for this crisis is working across those 3 bureaus, develop overarching guidance about what we see as the potential impacts, what we think are the top priorities to adjust programming. That guidance was then taken to the Nutrition Leadership Council, which includes leadership from those 3 pillar bureaus, as well as the regional bureaus. And we're sending that to our missions, which are present in countries, so that missions, USAID missions, can support their implementing partners and partner governments of how do we navigate this complex crisis in the ways that will do the least harm to nutrition. We also then organized just last week a webinar with the nutrition community with which we collaborate to share our thinking of the situation and hear back from colleagues, I think. And so I'm very pleased to have also this opportunity to continue to learn, to listen from people what's happening on the ground, what are the key priorities that we need to address. And we will be doing an external facing version of that guidance document, which pulls on guidance that has been created by many of the partners who are around the table today. I now wanted to focus specifically on the food systems piece, if I could go to the next slide. And I think of it, what's happening in the food system really is we're taking a triple hit. First of all, livelihoods are being hit. And we know that lower income populations, they spend a disproportionate amount of their income on food. As soon as as soon as purchasing power is hit, be it through reduced livelihoods or increased food costs, you have to prioritize filling bellies with calories. So you prioritize staples, and then you deprioritize more expensive foods, which are usually those nutrient-dense foods. And we've seen this in other crises, be it the global food price crisis, the Ebola crisis in West Africa. Faced with reduced purchasing power, you prioritize staples and you deprioritize nutrient-dense foods. The second hit is exacerbated because of some of the control measures. There's actually less physical access to a lot of these nutrient-dense foods because people are having less physical access to markets. Markets are sometimes being closed. And then if you are not able to go out but once per week, of course, your buying preferences are going to be towards products with longer shelf life. And then the third hit is then the producers and sellers of food, be it from farmers to processors to people working in the food markets. They're being hit, their ability to produce and sell is being undermined over time. So, what do we do within this setting? I think we first need to make sure we're sustaining the production immediately of safe cooks. I'd go back one slide, Ingrid, please. Yeah, to really sustain the production and marketing of safe and nutritious foods. We've seen that includes also fortified foods, especially fortified staples. I think that to me, this is a case that illustrates how important it is to ensure at least micronutrient security in the staple food supply, because while we want to have a more diverse diet and get nutrients from a variety of foods, because staples are the last thing to go in the poor's diet, we need to make sure that at least nutrients are being supplied there. We've seen some reporting, anecdotally at least, that some governments are actually waiving requirements of mandatory fortification, etc. We actually need to do quite the reverse, and if anything, actually use this crisis to say, if you're still putting import duties and taxes on the fortificants going into fortified foods, those should be waived. Also, we need to see if there are price subsidy schemes, that they are targeted to the nutrient-dense foods, which could include fortified processed complementary foods. We need to sustain the trade of the fresh foods and staples. If there are already programs to support community and local production of nutrient-dense foods, that we continue to support them. And that we work to make sure markets are open responsibly so people have access to the nutrient-dense foods. As we move into recovery, if we can go to the next slide, Ingrid. I think in addition to the efforts during this immediate response phase of how do we accelerate industrial scale fortification, how do we rebuild and strengthen the nutritious food value chain, I think we're seeing the production, the processing of nutritious foods taking a hit. A lot of the small and medium enterprises are taking hits. We need to support them so they can produce nutritious foods. I think we also are in a situation, when I started out in development, almost every country had a robust market information system, followed the price of a nutritious food baskets regularly. There's been de-investment in these sorts of market information systems, which really allow us to understand what's available on markets, what are consumers eating, what is actually the price of consumers, because when you see the price of nutritious food basket go up, you know that the most vulnerable populations are immediately going to take a hit. And that we also need to make sure that the trade and marketing policies are favoring nutritious foods, both the fresh foods and the fortified staples. So that is what I want to leave you with today, and to again thank you for this opportunity to share our thoughts and to galvanize action to really elevate the issue of nutrition during this pandemic. Thank you.
Thank you very much, Sean. That's really comprehensive, and I'm glad you you explained the food system impacts and also some of the ways in which USAID is thinking about what it is doing. And just to note that we will now open the Q&A session, and we are slightly short of time. We have 10 minutes, but let me ask if the kind presenters are willing to stay on for extra 5-10 minutes, and whoever is willing to stay on after that, please, that will be if you want your questions answered. We have grouped your questions, so it won't be necessarily individually. We won't post as you have written in the chat box, but we'll capture the topic that you have addressed. Let's do this. Let's take three questions, and then as written in the chat box, and then we will and there is a raise the hand function in the participants. If you go to participants, so you could raise your hand, and it will put you in the order that you have raised your hand, and we can take 2 to 3 questions and then go back depending on how we have time. But please, when you ask the question, let's keep it punchy to the point, so that we can continue to have more people engage with this discussion. Okay, there are so many questions and so many worries and the need for guidance. One more thing I wanted to mention is that the speakers have all mentioned some guidance documents and recordings and consultations they've had. We will source that, and we will send you a link as a follow-up email. I don't know when, but soon. Sometime this week, along with the link to the recording of this webinar, as well as as well as to these resources so that they're readily accessible for you. Some of you have asked these questions, and if we don't get to those, that's why we are not, because we hear you and we can easily send you that. So now to someone has either lots of people have lots of MacBook Airs, or there is one person with a very fancy computer here. So lots of questions from MacBook Air, and but there is Basanta Thapa, and this is to Joy. Do we know what the impact of disruption of services is having on outcomes such as low birth weight, fetal malnutrition, and disruption to various family planning services and reproductive health? And what do we recommend as interim services? I think that is there down the line for all the presenters, but I'll ask Joy to respond to that. And if, yeah, Joy.
Thank you so much. This is a really critical question, especially for intergenerational effects, the low birth weight and preterm. In terms of the direct effects of SARS-CoV-2 infection, there are early data suggesting a higher risk of preterm birth. For the low birth weight, quite a lot of that is likely to be through the indirect pathways, and we don't have data on that yet. So we've only got 3 months, obviously, of the epidemic, so of the pandemic so far. So I think what that underlines is the importance of collecting data and being more careful. We shouldn't just collect low birth weight, has a dichotomous variable, but we should collect birth weight and think of gestational age and really try and make sure we understand it properly. And then in mitigating effects, yes, the care at birth services, care for vulnerable, small and sick newborns and their mothers, but also going back to family planning and antenatal care and making sure those essential services are protected with innovations, mobile platforms, targeting, how to do that. And I thought there were interesting learnings from China, and I hope that we learn how to document those solutions, because everybody's going to need those. Thank you.
Thank you, Joy. We have a question for Anu, which is, I don't know why it's doing this. Okay. How did screening of pregnant women work in China? And do we know what will happen to babies born to mothers with positive diagnosis? This is from MacBook Air, Kajal Joshi, Paula Quigley, and Christy Amalba.
Thank you. So, at least, China hasn't had a new case of COVID now for I think a week, at least, if I'm not mistaken. But for Beijing, for sure, we haven't had a case in like 15 days. So no more new cases. But I think when in February, when we were at our peak, I think most of the pregnant women were tested if they were symptomatic. So they presented themselves and they were symptomatic, and then they were tested. And if they were found positive or suspected to have COVID, suspected if you were in contact, if you had through contact tracing, and then confirmed to be positive, then obviously and pregnant, then as I said, the option was really to separate neonates and from their mothers. I wanted to just sort of follow up a few questions that were asked if we were successful in getting the government to change their policy. Mm-hmm. No, but we are still continuing to work with them, in terms of sort of sharing with them as more and more data comes along, as more studies come indicating, just as Larry provided information, that we haven't actually seen any vertical transmission cases to date. And also breast milk in particular, we haven't seen any risk for babies. So yeah, even if mothers are sick, to maybe express and provide breast milk is a possibility.
Great. Thank you. And taking those additional questions as well, Anu. And so Larry, there are several questions. So we're not taking the names, but definitely Jill and Estraimer and several others. Well, I mean, in regards to misinformation and anxiety surrounding recommendations, how can we monitor and address this? which stakeholders are important here, but also questions, lots of them, as you have seen in the chat, about feasibility of actually executing some of these or implementing some of these by the mothers and households and communities, some of these recommendations that were put forth. Thank you.
So those are difficult challenges. Misinformation is always a problem. I think just in general, it's a problem. And certainly when there's a new virus coming out, getting good quality information out is challenging. We're trying as many avenues as we can to get the right information out, as well as trying to work with governments to try to harmonize that information. As I indicated, we've created a number of communication tools ourselves, tried to make those as accessible to people as possible. We've just recently revised the question and answers on WHO's website, working with UNICEF. We have the Global Breastfeeding Collective, that's an organization of 25, or a network of 25 organizations, trying to make sure that they are sharing the same messages and getting that out through every network that we can. So I would definitely call on all of the people who are on the call today to help in disseminating those messages. But we've seen this as a problem across the board with COVID, that there's misinformation, there's fake news going out that is distracting people from what they really need to do. And it's just a continuous fight we have to face. In terms of the feasibility of the recommendations, we do recognize the challenge. I think this is always a challenge when you're balancing multiple risks out there. How do you provide the best protection at the same time, recognizing that it's going to be very difficult for some people? And that's why we are addressing this question, as I said, in the new guidelines to address, well, what if masks are not available to mothers? What else should they be doing? And those become difficult challenges. I can't say exactly what the new guidelines are going to say, but I think we're certainly looking like we'll be saying you definitely should continue breastfeeding. You should be looking for other ways to try to minimize the spread of a cough with makeshift masks of some sort, perhaps cloth between the mother and the baby if you're a small blanket or such, to try to minimize that risk, because we do know that it transmits between people. We don't think that babies are necessarily completely immune to that, but we think the consequences are quite minimal. So we're trying to find ways to make it as feasible as possible, while at the same time not opening up the doors to, oh, this doesn't really matter at all. And finding the ways to do that in a global context where you have people with lots of resources and people with hardly any resources is certainly challenging. We're trying to find the best balance between them.
People had the similar concerns during HIV/AIDS, and that was even more problematic, considering that the virus itself could be transmitted to breast milk. So, at least this one, from what you're saying, at least we don't have that battle that we need to fight yet. And it is mostly about keeping the recommendations in place and making them as feasible as we can and remove the roadblocks. So one question to Sean, and I would then like to go to the people who are waiting in the queue, raising their hand patiently. So we'll go on for another 5 to 6 minutes, and we'll have to end with the hand questions, and then we'll try to see how we can address the rest. I can't promise that we'll address all of them, but definitely resources will be included in the emails. Okay, Sean. So there are 2 questions actually. Great point about fortification, comment about the need on how to keep vitamin A distribution for children going, but not unrelated to this is how do we keep the momentum around nutrition going to maintain both political and operational momentum to make sure that people have what they need.
Right, thank you. Thank you for both of those. And I'll, as many of you know, I worked in vitamin A supplementation for many years. And every country that had achieved high coverage, so for vitamin A supplementation, we've targeted you need to get at least 70 or 80% coverage twice per year to actually have the mortality reduction impacts that we aspire to. The guidance from the Global Alliance for Vitamin A is that given the situation, we should suspend campaigns, and that's similar to the guidance from WHO on campaigns for vaccination. So since most of that high coverage has come from campaign-type events, we're in a real dire situation that vitamin A supplementation coverage, which was already regressing, could really plummet. So I think there are two things that we need to look at. One, or perhaps three. One is when there are routine contact points, be it curative or preventive with kids through the health system, make sure we're trying to integrate vitamin A supplementation in there. Two, there may be situations where, despite social distancing needs, there are outbreaks that are where there's going to be a time-bound response. If that happens, to make sure vitamin A is coupled with that. And third, I think more generalizable, is we need to be working in parallel to make sure we have plans in place in countries of how do we actually get campaigns back up to catch up. And the good campaigns have not just been vitamin A, it's been bundling of vitamin A with catch-up immunizations, with where appropriate, screening and referral for treatment of acute malnutrition, and deworming. And so how do we actually have what I call shovel-ready plans and infrastructure, so that as soon as conditions on the ground permit to catch up the coverage of these essential life-saving interventions, we're out there and doing it. And it's going to be not just for vitamin A, but also I think things like catch-up immunizations, which Joy referred to, that we've been in a good situation, but we have real risks of backsliding. And then the political momentum I come back to, I think that part of it is we need to have a sound projection that is directionally correct about what the likely impacts are. And since everyone is focused on saving lives, to make clear that if we don't maintain a priority on essential nutrition interventions, we're going to be losing kids' lives, and that those kids who survive malnutrition during this crisis, we have undermined their potential in the future. So we really need to make sure we're engaging with policymakers who are really very appropriately obsessed with the response to the crisis itself, to make sure we're speaking in a way where we're adjusting our messaging to resonate with this current crisis, but to really make sure nutrition is not forgotten. Thank you.
Thank you, Sean. Now to 3, MacBook Air, do you mind? I don't know who MacBook Air is, but put your name in the chat, so at least that mystery is solved for me. And if you had a lot of questions, so do you mind if you don't get to your question? I'm Ronali. I see you as the first person to ask the question. So I'm going to unmute you, and could you ask your question?
Yeah, sure, Sunita. Hi, I'm Runali from Digital Green India. My question is to Larry. It's not a question, but a thought, because I find Larry's entire presentation is, I mean, I like all the presentations, but Larry's presentations on breastfeeding guidelines during COVID is quite useful and very, very important. But how do we disseminate all this information to the community? Can all these global bodies like UNICEF, USA, WHO, and maybe ANH Academy can play a role in that? Or I think that those are critical pieces of information. So my concern is how to disseminate this, or should we take help of national news channels or any other platform? So can you throw light on that? Thank you.
Larry, you want to take that question? Take that one now.
So the materials that I shared today are all available online. The links will be shared with this group. If you go to the WHO website, there are news stories about breastfeeding and COVID. It's in the Q&As. If you also visit the website of the Global Breastfeeding Collective, the messages on breastfeeding and COVID are there. UNICEF itself has quite a number of resources available about breastfeeding and COVID. Some of these statements are joint with USAID. So the dissemination, there are plenty of places you can go quickly, easily Googling to get these resources from many of us to disseminate them. We've tried to create them in multiple formats, and we're continuing to work on additional formats to try to get that out. So we're doing everything that we can to make that widely available.
Yeah. Thank you, Larry. And I also think as a community here, we should be seeking that out, even if they're somewhat difficult to find, reach out to people. that you know, and who can help you with that. But I think talking about how much all the speakers talked about misinformation, fake news, and so on and so forth. And it's important that we all are not a party to it and be like wise consumers of information. We are fortunate to be in this position, and it's important that we are all cognizant of what science is versus misinformation is. Thank you so much. IJ, I see your name as IJ here, and I'm going to unmute you. And could you ask your question, please? Sorry, it's moving.
Yes, hello.
Go ahead.
All right. My is not actually a question, but kind of comment, because I'm from Nigeria, and in Nigeria context, like that of breastfeeding, in rural have the knowledge.
We have lost you. Yeah.
Say the benefits of breastfeeding, and who have been finding.
Sorry, IJ, I'll have to mute you. Could you put your question in the chat box, because we are not
Very
able
difficult.
to hear you.
Hello.
We're not able to hear you. Could you put your question in the chat box? We are losing you.
Yes, can you?
Yeah.
Can you hear me now?
Question. Sorry. Can someone mute? Yeah.
Can you? Hello.
No, I'm unable to actually mute him as well. Meanwhile, I did. Okay, Kerry, I'm going to unmute you, and could you ask your question? And that will have to be the last one. Thank you so much for understanding.
Thank you to everyone for really interesting presentations. I'm Kerry from the London School of Hygiene and Tropical Medicine. I have a question about protecting the mental well-being of pregnant women and new mothers during COVID, because I think it's something that's easily forgotten in humanitarian settings. And just if anyone has any examples of doing this in wherever they are. Thank you.
Who would you like that question be addressed to? From Anu, or do you have any experience in China about that?
So not with pregnant women, but we did a lot of work with adolescents who have been, many of whom were stuck at home for weeks on end, over 12, 13 weeks. So there we did actually have a lot of work we did for, on mental health issues. But the point very well taken, that in terms of particularly around caregiver anxiety, which was extremely high both for pregnant women themselves, but for their children. A lot more work is needed, especially if we are moving to sort of online consulting and things like that. Health consulting becomes, healthcare becomes online, then helping health workers deal with how they will engage mothers and also address both their physical but also their mental issues is something we need to do a lot more on.
Thank you.
And this is Joy here, maybe just to briefly comment as well. I think we do have data from during the Ebola era. So, I mean, I think this is something that's universal. I think pregnant women all over the world, it's always a state of both hope and fear. And it's in a pandemic, which is a state of panic, it's magnified. So I think both the messaging, the misinformation, disinformation, and being very clear about that. We did a viral podcast from the London School on pregnancy just last week, and that may be a good thing to look at. So I think the information pathway, the care pathway, so on International Midwife Day, how we support midwives to still be able to provide services, even if those are at a distance. And then in humanitarian settings, it's an extra challenge. And I think it would be great if people collect innovations as those are happening. So, the mental health aspects will be broader, including gender-based violence and other vulnerabilities and so on. But there are also direct health consequences and higher risk of death as well.
Thank you, Lauren. Sorry, thank you, Joy. I don't know what's wrong with me. Thank you, Joy. And Sean, do you have any last remarks? Because all the speakers just spoke consecutively, so I thought maybe if you have any last remarks, that would be pretty much the end of our session now. We are 15 minutes, over time, and we'll have to end after that. Yeah, Sean. Sean, did we lose it?
Hi everyone. Sorry, Sunitha, if you can hear me. I think Sean's left. He had to
no
go
problem.
to another
Yeah,
appointment.
that's okay. So thank you, everyone. This has been wonderful. I must say I was very nervous about moderating a discussion with 500 people. And sorry, we couldn't take all your questions, but we got to most of them, I think. And please watch out for the links that we'll send and some of the resources. And we hope you remain interested in the ANH Academy and the March Center. And of course, there are several other resources and groups that you might be interested that are in the chat box. So thank you. Thank you. A big round of applause to our speakers for taking the time, and to all of you for showing interest in this topic and contributing so actively. See you all soon. Bye.
Bye-bye.
Thank you, Sunitha.
Thank you so much.
Thank you, everybody.
Thank you.
Bye.
And thanks, Sylvia, too.
Yeah, and thanks to my team. This is by no far. I have a large team behind me who have virtual behind me, who are in front of me, who have held this together. So if your question has got asked the way they compiled, thanks so much, my team, as well. Too many of you who helped on this for me to name now. Thanks.